Hey everybody, thanks for joining us this afternoon for today's version of Docs of the Shock here at Tennessee Department of Health. I am Dr. Michelle Fiscus, and I'm the Medical Director of the Tennessee Vaccine Preventable Disease and Immunization Program, and I'm here with Dr. Amelia Keaton, who is Interim Director of the Tennessee Department of Health Hospital-Associated Infections Program here. A little bit of quick housekeeping. All of the guidance that we present here may be completely outdated by tomorrow, so make sure that you are looking at the TDH website or the CDC website to make sure that you have the most accurate and up-to-date information. We will make these slides and a recording of this webinar available online on the TDH website. If you go to tn.gov/health, click on the yellow banner at the top for COVID updates, and then scroll down to the provider tab. You'll find a tab in there for the webinars that we've had for the last 3 weeks. All of the lines are muted because we have a few hundred people who are with us today. So if you have questions along the way, you can put those in the chat box, and we'll leave plenty of time for your questions at the end if they're not addressed while we're here in the first part of the call. So I'm going to pass this over to Dr. Keaton, and she's going to talk a little bit about what's been going on here at TDH and around the state.
Yep. So I was just thinking back that it's been about a week since we last spoke. It seems like it's been much longer than that, but just wanted to point out a few resources for everybody out there in case you don't already know about these. So our Incident Command Center was activated in January of this year. It seems, again, like that has been quite some time. Since that time, we've set up a clinical call line for advice and state public health lab testing approval. That's available from 8 a.m. to 10 p.m. And then we also have an overnight physician or epidemiologist on call 7 days a week for anything that happens after that. If you need to access that call line, I know a lot of folks are familiar with that already, but the number is 615-741-7247. We have plenty of people during the daytime answering calls. We know that despite that, there's still maybe some wait times there, but we're trying to get to everything as quickly as possible. For public general questions about COVID-19, we're asking folks to utilize the Tennessee Department of Health's public information lines. There are a few numbers there that you can use, and then also, but based on the major regions of Tennessee, there are specific numbers for those areas. There are call centers that are very well staffed at this point. Again, we don't expect any wait times, but depending on the call volume, you may have to wait for a few minutes, hopefully at most. All physicians out there, we hope, are now receiving our Tennessee Health Alert Network bulletins. We are trying to make sure that we release those whenever there's critical information changes or things that could affect your practice. If you're not already on that list, most of the contact information we have comes from our licensure and regulation folks. And if you aren't receiving those, please visit the website you see on your screen here to enroll so that you get any of those critical updates that come out. Again, we are still posting updates on our regular Tennessee Department of Health website, which you can see here. We're updating case counts every day. We're making sure we break those down by counties and by age as soon as we have them. We know that testing availability has improved, but it's still not perfect, so we're trying to make sure that folks have the most up-to-date information on our assessment sites, which you can also see broken down by county and area in the state by clicking on the COVID-19 assessment sites banner right there. So just showing a quick update on our case counts. So as of this morning, we have 957 lab confirmed cases of COVID-19 in Tennessee. As you would expect, those are concentrated around our metro areas. We have completed or obtained access to 14,909 test results. Those are performed both in our state public health lab and in commercial labs across the country. We know that of that over 14,000 tests that have been performed, 6.4% are positive, and 60% of the counties in our states now have confirmed cases there. Just looking at our epidemic curve, which graphs the case counts by dates and times, this week has been a time of massive increases in cases, which is pretty consistent with what's happening across the country. It's a little bit difficult to see on this, but you can also see the breakdown by county on this page as well. In terms of updated travel notices, these are changing as rapidly as you might imagine. There are now several countries that are listed as having level 3 travel health notices. Pretty much travel in general is discouraged across the board, particularly to these countries though. And in terms of clinical presentation, I think we have seen a lot more data come out in the past week in terms of the epidemiology and what providers on the front lines are seeing. So we know that the average incubation period is 2 to 14 days. That's something that we've known for quite some time, but we're seeing stronger data that the average incubation time is usually between 4 and 5 days. Most folks are considered to be at their most infectious points when they're having symptoms. So when they're doing things like coughing or sneezing, those respiratory droplets are thought to release the viral particles. There may be some role of asymptomatic spread. We don't think that that's the main driver of this epidemic though. And so, at this point, we're not able to make more detailed recommendations on those patients. We know, again, that elderly are the most likely to have severe illness, and they're also more likely to have an atypical presentation, meaning that they don't have the classic fever, cough, and respiratory symptoms. They may have more generalized, nonspecific symptoms that can range, in addition to cough, to things like body aches, GI symptoms, which is something that we didn't appreciate early on in this pandemic, and then shortness of breath, which I think is something that we have recognized as a regular symptom. In terms of laboratory abnormalities, some of the things that we're seeing, as we collect more data are things like elevated transaminases, which is a pretty common finding with any systemic viral infection, and also lymphocytopenia, which would be consistent with a viral infection as well. Chest x-rays and chest CTs can show anything ranging from patchy infiltrates to ground glass opacities. In milder cases, you may not see any abnormalities at all. But it is important to know that even though you don't see things on chest x-ray or on chest CT, that doesn't mean that a person may not progress to having those symptoms down the road. Despite that, though, we also still want to make sure that people are aware that over 80% of individuals who are infected with the virus that causes COVID-19 will have a mild illness, meaning that they likely won't need hospitalization and can take care of most of their symptoms at home. There's been much more data made available in terms of the symptoms and testing results of children with COVID-19. As a pediatrician, that's something that I'm really excited to see. Seattle Children's Hospital, which is somewhere that was hit pretty hard early on in this pandemic, they tested 600 children with symptoms. Of those 600, 4 tested positive and 1 was hospitalized, so pretty promising results there. Vanderbilt Children's Hospital right here in Nashville has tested 119 pediatric patients so far, and of those, only 1 has tested positive, suggesting that a lot of time, in most cases, children with symptoms of cough and fever usually have something else going on that wouldn't be COVID-19. In terms of acting on these testing results, Vanderbilt is now recommending that only children who are most at risk for severe complications of COVID-19 be tested. And some of those groups include outpatients with fever and respiratory symptoms who have a known exposure to a COVID-19 positive patient, or those who have underlying medical conditions that cause immune compromise, or who have chronic cardiac or respiratory disease or type 1 diabetes, just because those tend to put patients at higher risk for most infectious illnesses in general. In terms of the issues that we are hearing repeatedly, one is that most primary care physicians and outpatient providers don't have enough PPE, and we know that this is incredibly frustrating. Unfortunately, we here at the Tennessee Department of Health don't have PPE to distribute, but my team, which is the Healthcare Associated Infections team, is happy to try to work with any provider who needs help in terms of PPE optimization and reuse. In terms of requesting personal protective equipment, we have a couple of resources that we just wanted to share with you. These are not ones that I think outpatient or primary care providers tend to use most frequently, but they would be your local healthcare coalitions, which tend to be a resource thought of mainly by acute care hospitals. We've heard some great news, though, that those healthcare coalitions who specialize in emergency preparedness have been pretty creative and proactive in getting PPE out to folks who need it aside from hospitals. You can locate those by Googling your county and just the words healthcare coalition. Other folks have had some luck going through other county emergency management agencies, which again would be something that you can Google online. Fortunately, despite our PPE shortages, we are seeing a dramatic increase in our testing capacity, and that's getting better every day. Unfortunately, anytime that there is something, a large infectious disease outbreak, there are labs and there are individuals who are trying to capitalize on that, maybe with testing and equipment that is not FDA approved and that may not give you valid results. And so we urge everybody who wishes to test for COVID-19 to go through the Food and Drug Administration or FDA website to look at a list of their labs that are approved and confirmed to do good testing for COVID-19. In terms of conserving PPE, there have been a few webinars this week focusing on strategies for doing that. So one was led by the CDC and their Coca-Cola campaign, which you can access at the website there. They also have posted a link to that on the CDC Facebook page with the link there. A few other resources that I wanted to share. So Emory University has a few really great printout tools and also videos on how to either do extended use of personal protective equipment or how to reuse it appropriately and how to reprocess some of those items such as eyewear. I think this is something that is new to all of us. I, as an infectious diseases physician and most infection preventionists out there have never really been in the position of needing to reuse or try to conserve PPE because we've always had an ample supply. And so I think, trying to find resources that you feel comfortable with and get comfortable with those before you find yourself in a PPE shortage situation is always ideal, but I think these are some really great resources to do just-in-time training if you need that. And again, feel free to reach out to us if you have specific questions about items that you're using. And with that, I will turn things over to Dr. Fiskus.
All right, so a few updates about lab testing. So commercial labs are still available, and there are more commercial labs coming on all of the time. Again, as Dr. Keaton mentioned, you'll want to go to that FDA page that was on the previous slide just to make sure that the lab that you're using is one that's been approved to be able to do this type of testing. Most of the commercial labs that we're hearing about have had turnaround times somewhere around 4 to 5 days, but there have been some labs that have taken up to 2 weeks to get results back. So you may also want to reach out to your individual lab to make sure that you have an understanding of what to expect and what to tell your patients when you're sending labs out to outside providers. You do not need to call Tennessee Department of Health to get permission to send a lab to an outside lab facility. You can use your discretion to decide who should be tested and who should not within your practice. But make sure that when you're collecting the specimens for those labs, that you're using that particular lab's guidelines to make sure that you don't have things held up because you don't have proper paperwork or because you have a sample that wasn't able to be processed. Most of the commercial labs will only work with providers that are contracted with them. So you'll also need to consider what that contracting process might look like if you're not currently in an agreement with a commercial lab. Remember, please, that if you are notified with a positive case, that's immediately reportable to the Department of Health. You can call your local county health department to report that. In some cases with outside commercial labs, you may get a result that you have a positive case in your practice before the Tennessee Department of Health is aware of it. So we do get those positives pushed to us eventually, but sometimes there can be some delay from the commercial labs. So please just assume that we don't know and call the county lab or call the county health department and inform them of that positive. We'd rather be over notified than and have someone potentially slip through. Alternatively, you can fax those results to the number on your screen there if you'd rather do that instead of calling your local health department. There's also laboratory testing available through some of the healthcare systems. The predominant one has been Vanderbilt, but there are some that are trying to come online, and you may hear of that more over the next week or two, that some other large medical systems have been able to get testing. And then they set their own rules as to what their threshold is to test individuals, or whether or not they have to be someone who's been seen within their facility. There's also remote assessment sites that have been set up all over the state, and the link for that, if you go to tn.gov and then click on the red banner at the top of the page and scroll down a little bit, you'll see a blue box like the one on your screen that says remote assessment sites. This is the same place that Dr. Keaton mentioned a little bit earlier, where you can find remote assessment sites by county, and then there's a phone number so that you can call and find out what time they're operating and what their procedures are. In most of those cases, or many of those cases, they'll ask you screening questions over the phone before you go over there for testing, because we do not want to be testing asymptomatic individuals at this point. If you, as a provider, want to request testing through the State Public Health Lab, you also have that option. We would like to see those tests prioritized to people who are symptomatic and who meet certain criteria, that they're a direct contact of a laboratory confirmed case of COVID-19, they've had travel to a high risk, either international or domestic location, where there's been widespread community spread of the virus, that they are pregnant or severely immunocompromised, that they're in a high risk occupation. So we would prefer to test the healthcare workers that get exposed and are symptomatic through our state lab, or anyone who's working with elderly patients or at risk populations. For example, if you have maybe a prison guard or an inmate who has symptoms, we would like to expedite those tests through the State Public Health Lab. If they have acute respiratory distress syndrome of an unclear etiology, or if a patient does not have insurance, we can process that lab free of charge to them through the State Public Health Lab. So you do need to call the provider line to get authorization to send that specimen up to the State Public Health Lab. And the turnaround time here has been about 48 hours or so. If you're submitting samples to the State Public Health Lab, there are a few different options for you. You can use a polyester swab with a plastic or metal handle that's submitted in viral transport media. That's the pink stuff that you use for herpes testing. A lot of you have that in your office refrigerator. You could send a polyester swab in sterile saline in a sterile test tube that has no additive. Or you could use something called an e-swab in Amy's media. That's something that you are probably less familiar with, but also a commercially available product that can be used to submit tests to the State Public Health Lab. And when you're talking to patients where you're submitting laboratory testing for them, it's really helpful if you give them some idea about expectation for lab turnaround. So generally, if it's a high-risk patient and you're submitting a sample to the State Public Health Lab, you're looking at a 2 to 3 day turnaround. If you're sending it to a commercial lab, it may be between 4 and 14 days. So let them know what to expect, and that you will let them know when their test result is in, so that they're not calling the local labs or calling up to the state public health lab to get results. Let them know that because you're sending a test, they are to go home and self-isolate for 7 days, or plus 72 hours from when they return to wellness. If their test result ends up not being back within that period of time, then if they have returned to wellness and have been well for 72 hours, they would have served out their isolation at that point and could return to their usual activities. Any household contacts are to be quarantined for 14 days from the time when the individual who is infected returned to wellness. So that could be sometimes 21 days or so in some situations. And on your screen, you'll see some links to one-pagers that we've developed that you can provide to patients who have been tested or who have been contacts of people who've been tested, so that they have some understanding in writing of what to expect. For treatment for COVID-19 patients, it is still only supportive care that's available. There are no FDA-approved medications to prevent, treat, or cure COVID-19. There have been some folks talking about chloroquine or hydrochloroquine and Zithromax, maybe in combination. Those medications are not FDA approved to treat COVID-19 patients or to prevent COVID-19. There is minimal data to suggest that those medications are effective, and those combinations of medications can have very serious side effects, including QT prolongation in susceptible patients. So please do not prescribe these medications for prophylaxis or treatment for COVID-19. Commissioner Piercy, who's the Commissioner of Health, issued a memorandum yesterday also stating that these medications should not be used for prevention or treatment of COVID-19, and reminding pharmacists that they should use their discretion if they're presented with prescriptions for patients who may not meet the need for the treatment of chronic conditions with those medications. There is at least one medication that's currently in research, and that's remdesivir. This is a broad spectrum antiviral medication that has been previously used in adults with Ebola, and has some animal studies to suggest that it may be helpful in MERS and SARS cases. There are currently clinical trials going on at the University of Nebraska and some compassionate use on a case-by-case basis for those patients who are critically ill. They are currently applying for broad compassionate use of that medication, but again, that is only in patients who are critically ill, where they've exhausted the other opportunities to try to improve their conditions. I wanted to address a few common questions that we get. So the first is, do we test asymptomatic patients with known exposure? And the answer is no. We want to discourage testing of patients who are asymptomatic. If they have been exposed to a lab-confirmed case, they should be quarantined for 14 days from the time of their last exposure and should only be tested if they're symptomatic. And the reason for that is if you test an asymptomatic individual today and their test is negative, it could be positive tomorrow, and you're not going to go back and retest these individuals every day. So the test results can give a false sense of reassurance that someone is not infected when maybe they actually are. Second question is, do we quarantine the contacts of people who are exposed to a lab-confirmed COVID-19 patient? So we do not worry about getting degrees of separation away from people who are confirmed cases. So there is no need to quarantine the contact of a contact of someone who's been exposed. The one caveat there is that you may want to furlough healthcare workers who are household contacts of symptomatic individuals while their test is still pending, because we don't want to be in a situation where that test comes back positive and now you have a healthcare worker who's continued to work in the facility when they would actually warrant quarantine and could potentially be infectious. But in general, there's not a need to quarantine contacts of COVID positive patients. And if you have an individual in the office who's later confirmed as a case, what do you do about your office staff? So those office staff who were within 6 feet of the patient for more than a few minutes and were not masked need to be furloughed and quarantined for 14 days from the time of that exposure. And but critical healthcare workers who do not have symptoms may work if they wear a mask while they're in the facility at all times and self-monitor for symptoms. Some ways to avoid exposures in the office so that you don't have to worry about furloughing your staff are to make sure that you post a sign on the door asking for any patients who have symptoms that are consistent with COVID to return to their cars and call into the office, to meet those individuals who are symptomatic with a mask, and make sure that all of your employees that are going to be within 6 feet of that person are also masked, to get that patient into a room and close the door so that they're isolated, and make sure that those who are in direct contact with symptomatic patients are wearing eye protection, a face mask, gloves, and a gown. But the one caveat is that if you have a provider who was not gowned, who had contact with an individual, but they had all the other PPE in place, they would not be quarantined but would instead be told to self-monitor for symptoms. And then wash hands and clean those surfaces in the rooms between each person who has been in who may be suspect. Make sure that you have a very strict policy in your office that no one comes to work sick, and that they should remain isolated at home for at least 72 hours from when they return to wellness, and have no exceptions to that, which in some cases may mean that you have to close your office for a day or two. But your being proactive in that is what's going to stop people from having massive exposures to folks that are sitting in your waiting room or large numbers of people that are coming in for evaluation in your office. And then I wanted to give you a little bit of information about updates in telemedicine, so that maybe those who might be hesitant to use telemedicine can feel a little more comfortable about that. So Medicare has released updated guidance that allows for telephonic and virtual case care effective March 6th. And that covers any virtual visit for an established patient in your practice who's covered under Medicare. And it waives the HIPAA requirement so that you can use any non-public facing remote communication product. So that means FaceTime, Google, Google Hangout. You can Skype. You can use anything that you want to use to be able to connect with that patient. Medicare also allows you the opportunity to reduce or waive the cost sharing that those patients may be charged if they're assessed. Similarly, the TennCare MCOs in the state have all released statements about telephonic and virtual care. So Blue Cross Blue Shield, all of their products across both TennCare and their commercial products are covering telephonic and virtual care through April 30th, and all of these MCOs have said that they will extend this date if they need to. We've included the CPT codes that you need to use for telephonic care or telephonic and virtual care. Basically, you can bill those the same way you would bill an office visit. There are some codes on your screen for behavioral health consult calls. What you need to do is make sure that you're listing the place of service code as 02 for all of the visits, and that indicates that the patient is at home. And that's the case across all of the MCOs and insurance companies. You wanted to note that that the place of service code is 02 on all of those claims. United Healthcare has similar guidance. They are sticking right now with the guidance that has been in place that you can only do telephonic or virtual visits with your established patients who have not had a visit in the last 7 days and don't have a visit within the next 24 hours. And I've included some codes there as well, even codes to be able to bill for talking to patients through your patient portal can be billed through United Healthcare, and given you their resource website where you can read about these policies in detail. AmeriGroup is covering telephonic and virtual visits at parity to office visits, and they say just bill as you would any other office visit that you would provide. And again, use that place of service code of 02. TRICARE is only covering virtual visits. They're not doing any telephonic care or text or audio only care. And they do say on their website that you may need prior authorization or referral before you can use that service for your patients. So just check with TRICARE before you provide those services to them. And then Cigna is allowing virtual visits related to COVID-19 at no cost to the patient, but virtual visits that are non-COVID-19 related are covered through May 31st and may incur some out-of-pocket costs for your patients. And again, for all of these MCOs, we recommend that you go to their individual websites and look at what their updated policies are. They're very easy to find if you just go to their main website. They all have a COVID link right on their homepage that can take you to what their current guidance is. So again, our web address at the state is tn.gov/health. And to get COVID updates, you can click on the yellow banner at the top. That will take you to all of our resources. Those resources are updated almost every day. The red banner at the top takes you to the governor's page, where you can find those assessment sites, remote assessment sites listed, and some other information, including the governor's press briefings that go out. Those are recorded and archived there. You can also go to the cdc.gov/coronavirus website for resources. And with that, we will start taking your questions. So if you would like to ask a question, you can put it into the chat box. Our great emergency preparedness colleague, Peter, is putting those up into a list for us, and we will address those as you send them in. So you want to take the first one?
Yep. So the first question we have is, other state pharmacy boards have restricted chloroquine products. Any plans to do that here? The governor's statement this morning wasn't strong enough. So I think at this point we are still we're still trying to figure out the best way to tackle this problem. I think, we released some fairly strong language yesterday through our Commissioner of Public Health here in Tennessee, Dr. Lisa Piercy. That stated that these, medications have not been studied well enough, and that there is not an indication to use those, on otherwise mildly ill patients. Our pharmacy board may follow suit on that, but I don't think we have, good information as to what their plan is at this point.
And someone was kind enough to correct me that the place of service code 02 means telehealth and not home. So correction made. Thank you for fixing that for me. Our insurance company is accepting well checks for telephonic visits, and our EPSDT criteria lowered than for this. So don't have specific guidance around EPSDT criteria for telephonic visits. There are some folks that are doing the history portion of the well child check telephonically or via video chat, and then bringing the child in for a more abbreviated well visit. We obviously still want to prioritize vaccinating children on time, which would require a face-to-face visit in your office. If you're unable to continue to get those vaccines done, then the priority is to get those children who are under age 2 vaccinated on time, so that we can avoid having any kind of vaccine preventable disease outbreak on top of what we're already dealing with. So you may end up doing some kind of a hybrid between some of the care being done telephonically and some of it being done in your office. Many practices have resorted to having well visits in the mornings and sick visits in the afternoons to allow some space, or large practices have resorted to having, quote, clean teams that only take care of well visits and screening those kids when they come in for well visits to make sure they're not also ill, and then having a sick team that works with the children who are symptomatic. And we lost, there it's back.
Yep. Shelley, I might have to defer the next, or there's a billing question. Any guidance for inpatient billing codes for patients in isolation with COVID-19 or who are a person under investigation for COVID-19 for whom direct physical exam cannot be performed?
Yeah, that's a good question. So this is specifically asking for inpatient billing adjustments for patients who are in isolation because and where the provider can't do an exam because there's a PPE shortage. I don't have specific guidance on that at this point. I think, likely the best thing you can do is document what the situation is. Clearly, if someone is hospitalized, someone's going to need to be doing an examination on them in some way, shape, or form. So that may be something where you're able to get together with colleagues and designate who the one person is who's going to don the PPE and go in and see that patient. But you may also contact your medical society, who may have some information about specific billing, or your healthcare facility that may have information about that. We'll see what we can find for you in the interim.
Yeah, I kind of echo Dr. Fiskus's sentiment that most inpatient facilities have pretty strong billing departments who might know some of the ins and outs of that specific question. Let's see, the next question that we have is a patient who is hospitalized and seriously ill. Are we saying that they should not be treated with hydroxychloroquine and azithromycin, or that these patients should consult with their attending and ID to decide on a case-by-case basis? So I think at this point, our main message that we want to convey here is that these interventions have not been studied. The studies that have been released on these with relation to COVID-19 are small. It's really difficult to make any kind of conclusion from those. I think if a patient is critically ill, that certainly would be the time to consider it, but I would absolutely make those in consult with a critical care physician and an infectious diseases physician, just because there are, those, particularly hydroxychloroquine has some pretty significant side effects. Azithromycin can as well, and I think that's probably a little bit out of the scope of what we're able to say at this point in terms of what to do in that situation.
So the question is 4 to 5 days post-exposure when a test is most likely to be positive. In other words, least likely to be false negative. So I think the going thought is that we're more likely to get a positive test when patients are most symptomatic. If for nothing else, then maybe because we get a juicier sample from them if they're snotty and coughing when we get those samples. We certainly do expect that we're seeing a number of false negative results. We don't have any way to quantify that. But in general, yes, I think we would agree that when patients are at their peak of symptoms, they're probably more likely to have a positive test than not.
Correct.
Do you agree?
Yep, I would definitely agree with that. We have a question that asks, are there any changes or recommendations in wearing masks when rounding at multiple hospital nurseries? So that is a great question, and we know that nurseries are a situation where you often have multiple babies in one relatively closed space. I think historically we have asked providers who are not symptomatic to not use masks, primarily just as a way to conserve PPE. I think if you are somebody who is going from facility to facility, I would probably consult with that specific facility and see what they would prefer you to do. Obviously, if you feel safer doing that, that is an option for you. But it's not something that we have really specific guidance on, I guess is the short answer there.
So what's guidelines regarding burials and funerals currently for non-COVID-19 positive patients? And really I think the guidance is the same whether the patient is positive or not. And there are specific guidelines on the CDC website that you can look at, but in general, you still want to try to have that 6 feet of space between folks and to have some ability to be in an airspace where there's not going to be a great chance for swapping respiratory droplets with someone. I've seen many cases where people have had virtual services for their extended family and have had more private, smaller scale services to accommodate just close family and friends and haven't had large gatherings. I'm not sure what's going on with respect to local restrictions on gatherings at funeral homes, and that's probably county government specific as far as what types of restrictions have been put on and over what dates.
We have a question asking about measures and guidelines for juvenile detention centers. So I think this would fall under loosely a congregate care setting, so somewhere where people are likely to be roommates or to be in communal settings at certain parts of the day. I think just as we're recommending for anybody else in the community, try to avoid gatherings of any kind, which again we know is difficult in detention or correctional facilities. But I think this is a situation where all bets are off and we really just have to be incredibly cautious, even if it seems like the measures are severe. I think in particular for situations like that, I would take a really good look at your environmental cleaning services and your cleaning protocols and try to ramp those up as much as possible so that if you have a situation where multiple people are within the same confined area, that those areas are getting cleaned multiple times per day. I believe that CDC might have some more detailed guidance on what to do in correctional facilities. Don't quote me on that though, but I'll certainly look into that and see if that is something that's out there.
And we've had juvenile correctional facilities specifically reach out to us as well with questions, and have provided them some guidance. So it may be that guidance isn't always filtering down to the facility level, but there is guidance that's been shared with their reporting structure. Should children with fever and diarrhea be screened as positive, and precautions put in place given the possibility of GI symptoms? So I think that the data is pretty good that we don't have to have high suspicion for children who are ill having coronavirus infection, given the numbers that have come out of Seattle Children's and now out of Vanderbilt. Obviously, enteric precautions are something that you'll want to use if you're dealing with a child who has GI symptoms, just as a general rule anyway. But if you have a child with just diarrhea, I don't think there's currently strong recommendation to test them for coronavirus.
The next question we have is regarding the sensitivity and specificity of the test being used. I personally have not seen hard numbers on this. I think that's also something that's going to vary somewhat by the person performing the test. I can say based on what we know for molecular-based testing like PCR, they tend to be, very sensitive. And I would also say that for this, we've also heard that they have a very high specificity as well. I don't have exact percentages for that, unfortunately.
Information about use of steroids in seriously ill COVID-19 patients. So use of steroids just to treat someone for COVID-19 is currently discouraged because it is associated with higher morbidity and mortality in those patients. So the recommendation currently is to use steroids if you have to use them for a comorbid condition. For example, if a person has asthma and COVID-19 and you need to treat the asthma with steroids, then that may be something that you need to do. But right now there's not good evidence to support using steroids for someone just with a coronavirus infection.
The next question we have is, how often should we be re-seeing or checking positive patients? So I think that depends a little bit on the situation. I think if somebody is experiencing mild symptoms, you can just provide really good anticipatory guidance that if they feel like their symptoms are worsening, they're having difficulty breathing, those sorts of things, that they should absolutely feel free to contact you or to seek medical care. If you have the bandwidth or, any concerns about a patient, you can certainly try doing calling and following up. But I think, based on what we know, if somebody has mild symptoms and is otherwise doing well, there's not necessarily a need to see them unless they feel like their symptoms are worsening.
The next question is, what evidence supports the 7 days plus 72 hours from feeling well for positive patients for the length of their isolation? Because there are reports of viable virus longer than that. So there have been reports of virus RNA being detectable for longer periods of time. That's not the same as someone being infectious. So currently what CDC's guideline is to consider them infectious for 7 days plus 72 hours from the resolution of their symptoms. And I'll defer you to CDC as to their rationale for that.
And I will say that we know that the shedding dynamics are probably going to be different for every person based on their immune system and just differences between individuals. I think the 72 hours from feeling well is probably a pretty conservative estimate. If you look at other illnesses that we have, we typically don't make something that specific. Most people are allowed to return to work or to return to school or other activities within 24 hours of their fever resolving. So I think I would feel fairly comfortable with that 72-hour mark, just because it's meant to kind of accommodate and account for some of those differences between individuals.
Do you have a recommendation for how outpatient clinics should provide bronchodilators for possible COVID-19 patients if needed? Yes, so it is considered an aerosolizing procedure to give a nebulizer treatment to someone. So if you can use MDI and a spacer mask to provide bronchodilators, that would be preferable. If not, then those who are working with that patient will need to be in full PPE, including an N95 mask, if at all possible, because of the aerosolization.
I will also add one qualifier to that, though. I think we have some fairly decent data out there suggesting that even though a nebulizer treatment, obviously, if you're in a room with one of those, does look like an aerosolizing procedure, the majority of the aerosols that you're seeing are actually not from the patient. So it's usually, vaporized oxygen or the medication. And so I think even though we absolutely recommend wearing PPE, that's probably lower down on the risk, in the risk category in terms of aerosol generating procedures.
Any truth to reports to avoid ibuprofen in use of COVID-19 or suspected patients? So it's probably a little out of our purview for that specific recommendation, but there was a small study that came out, I think from Italy, that tried to associate ibuprofen use with increased morbidity in these patients, and it was a fairly small study, and I think the consensus at this time is that ibuprofen is probably okay. Have you heard more about that?
I haven't. I will just say, just from a research perspective, I think that would be a really difficult relationship to prove, because I think people who are experiencing more severe symptoms are probably more likely to be taking things like acetaminophen and NSAIDs. So I think we would just need more data before we could say something more definitive on that.
So there's a question about how long do you need to keep a room empty after you've had a suspect patient, and the guidance around this, unfortunately, is not concrete, because so much of it depends on, was the patient masked, was the patient coughing in the room, what is your air turnover like in the room, and so hospitals often know what their air exchange rates are in their rooms, but most folks who are out in practice really have no idea about that. So we've seen numbers like 2 to 3 hours. Sometimes that's just absolutely not possible to maintain in a small private practice where you may only have 2 or 3 exam rooms to have rooms sitting open for 2 or 3 hours. So I think what we would say is leave it open for as long as you can. Wipe down the surfaces, and you have to do what you have to do to be able to take care of your patients and get through your days.
Let's see, we have a question that states, healthcare workers who have tested positive after appropriate resolution of symptoms, do they need a negative test prior to returning to work? So at this point, CDC has 2 different strategies for screening a screening a healthcare worker on being appropriate to return to work. One is based on testing. We have not seen widespread use of that, obviously, because testing is still not as readily available in all areas. The other alternative, I think, is to just use that 72 hours after feeling well again and being afebrile, particularly if they've already made it to that 7-day point where, it's been 7 days since their symptoms started and their diagnosis happened. So that's what we have been advocating. I think some people where testing is more available may choose to do that. We don't necessarily recommend that. And there's some more specific guidance out there on, when the employee does return to work, should they wear a mask or not? And CDC, I think, has some really good details on that might be helpful to review if that's a situation you find yourself in.
So can you release a patient who's been tested but results aren't back, and the patient's better by day 7 plus 72 hours of wellness? And the answer is yes, because even if you had gotten a positive test back that day that you tested them, the recommendation for isolation would be for 7 days plus 72 hours from return to wellness. So yes, you can release that patient. If you get a 14-day test that comes back positive, they've already served out their isolation, and they can, it was fine to have let them back out.
We have a question, let's see. If a patient is tested and ultimately tests negative, what is the guidance regarding removing isolation or masking, etc.? So I think if they test negative and they were tested at a time when they were symptomatic, I would follow just the routine guidance that you would follow for anybody else who has respiratory symptoms or a fever. If they're feeling well, I think they should stay home from work if they can control their secretions. They certainly could work. I think probably the safest option in any healthcare worker or any person who is tested and is going to work and is still having those symptoms is probably to wear a mask, but I think it would just have to depend on the environment that they're working in. We have a question, should we check a CBC or LFTs on all suspected positive patients? So I would say no. I think, as we've kind of mentioned, the majority of people are going to have mild symptoms, and I think we don't necessarily know the significance yet of those findings of lymphocytopenia or transaminase or elevated transaminases. I think if the person is ill enough to be hospitalized, you could think about checking some of those. But on your typical outpatient person who is getting tested for COVID-19, I don't think I would check those unless there's another clinical indication for it.
And then for orthopedic complaints in asymptomatic patients with no known exposures, is it still okay to recommend NSAIDs or oral steroids for musculoskeletal complaints? Yes. So it's fine to continue to recommend what you would typically recommend for patients in whom you don't suspect any issues with coronavirus infection. So that is all we have right now from questions. And we just want to say that we appreciate everything that you're doing. It's obviously a very stressful time, and I'm so impressed with the stories that I see, especially on social media, of innovation out there from everyone from suddenly ramping up telemedicine to figuring out how to change workflow and their practices to both protect their employees and their patients. Everyone is doing everything that they can to address this, and we just really hope that you continue to stay well, and that we'll get through all of this hopefully sooner than later.
Yeah.
If this is something that continues to be useful for you as a format, please let us know. You can say something on the TDH Facebook page. We'd be happy to do this again next week and give you more updates. It's obviously a very rapidly changing situation all the time. We have new information to share. And again, be sure to go to our tn.gov/health webpage. Click the coronavirus banner at the top, and that takes you to all of the updated information that we have. New case counts will be out in an hour, and we hope that y'all have a great weekend.
Yep, and I will also just acknowledge, just from the healthcare associated infection sides, we completely understand that these issues with personal protective equipment are frustrating. They're unprecedented. We are learning along with you the best way to address these. So please, keep reaching out to us with any questions or specific situations. We're happy to help. It looks like we got another question that is Tennessee considered an area of widespread community transmission at this time? So I don't know if there's been an official classification of this. I think we know enough just from an epidemiologic perspective that it is spreading in the community. I don't know if it would meet the criteria for widespread transmission, but I think it is definitely out there and is something we all have to consider here.
And do you want to answer the one about the ER?
Yep, so I work in the ER. How should I proceed when I come back home from work about undressing myself? Great question. So I don't know if we, again, have any great guidance on this. I will say probably best to remove your clothes as close to your front door as possible and wash your hands really well. We're not recommending specific laundering practices, for healthcare facilities or for, personal folks who are taking care of patients. But I think the most important thing is wash your hands regularly and consider changing out of your clothes as soon as you get home.
And then one asking, are strep tests considered aerosolizing procedures? They are. Anytime you're putting a swab in an orifice where someone could end up coughing or sneezing, then that's considered aerosolizing. So if you're doing strep tests, you should make sure that you have on the best protective equipment that you have available to you.